Class, this is my case study response for pulmonary embolism. Patient Tobias is a 61-year-old male presenting to the emergency room with chest pain and shortness of breath after having a syncopal episode at work. His past medical history includes cardiovascular disease with the previous stent to the LAD, hypertension, IV drug use, and untreated hepatitis C. Tobias reports that he is a pack per day smoker and prior IV heroin use, but does tell the triage nurse that he hasn't used in 3 months' time after an overdose. His vital signs are heart rate of 112, blood pressure of 84/40, respiratory rate of 22, that is rapid and shallow. He's afebrile, and his pulse ox is 86% on Romair. An EKG is showing a right bundle branch block without a previous history on EKG review. So the patient is placed on supplemental oxygen, and his SpO2 improves to 95% on 4 liters nasal cannula. The suspected diagnosis is a pulmonary embolism due to the decreased SpO2, tachycardia, hypotension, and his reports of chest pain. The patient had basic lab sent of a CBC, BNP, cardiac enzymes, and a D-dimer. The results of the D-dimer are 4.6 milligrams per liter, which is considered high, as a negative D-dimer is less than 0.5. A bedside echocardiogram indicated a positive McConnell sign with a severely dilated right ventricle and interventricular septal flattening in the setting of a presumptive pulmonary embolism. The patient is sent for CAT scan and found to have a saddle PE. A saddle PE is where it actually saddles the main bronchial branch and can cause a severe enough obstruction. So the discussion to start heparin drip versus the need for surgical embolectomy with the team to address treatment options. And it was determined that a surgical embolectomy was needed in this case. After removing the thrombus, the patient was started on anticoagulation therapies before discharge, and the right bundle branch block was noted to have been resolved. And those are my references. Thanks.